Chapter 23, The Hospitalized Child. Comfort is important, as being hospitalized is unfamiliar, stressful, and uncomfortable. Pain and physical discomfort may be caused by many sources. You must assess pain, manage appropriately. Erickson. Development of trust and mistrust versus mistrust. Toddlers want autonomy. Less in hospital. Less autonomy. Preschool. They have magical thinking. They think that they caused their illness. School age want independence. They feel powerless. Adolescent trying to work on self-identity should be supported and educated. Education and options of treatment can help give patient autonomy. Family should always be there. They will always be there, so need education on treatment, rehab supplies, and how to use resources that may continue after discharge, such as feeding tubes, dressings, etc. Hospital settings. Not all facilities have pediatric unit, but if possible, the child must have orientation on the unit. Child life specialists can provide tours, medical play, and explain policies for family and procedures for children. During acute hospital visits, they may not be able to have tours or orientation, but they can see some vitals equipment or even an empty room to help them acclimate. They usually have a playroom where there's no med or discussion of procedures, nothing is done there. This is for a patient and siblings, their family. It's a safe place. For the immunosuppressed, the patient should have a neutropenic playtime after services are cleaned appropriately to prevent acquiring of infectious diseases. Admission responses, which are page 404, 403. Protest. This is important. Screaming, agitated, forced to interact with strangers can last hours or 1 to 2 days. Despair. Child withdraws, becomes inactive and uncommunicative. If parents return in this stage, is often ambivalent or sad. Detachment or denial. It appears that child is adapting to the absence of parents and family, may interact with others, play in bed, or participate in a playroom. It appears to be adjusting, but still experience sadness, may ignore parents to punish them for learning. This is normal. It's raining. Hang on a second. Okay. Continuing to offer child the support, positive play, and interactions, consistent routines. Parents can leave a familiar item with them and reassure they will return. Consistent staff is beneficial to the child as they have reduced stranger anxiety, continuity of care, and the nurse should establish a rapport with parents first, as this helps the child to trust the nurse. Assess the child in the parent's lap. That is the best time to assess them. It's raining. Regression. Behaviors used to cope with stressful events, such as thumb sucking, baby talk. This is a normal response. You should not punish, but you should have positive encouragement. Children are not little adults. Never let them in a hospital bed. You need cribs. Need more sleep than adults. Should be encouraged to sleep on a regular schedule and give extra naps, not go to sleep as soon as their home routine says go to sleep. Follow that routine. Lots of interruptions for vitals, weight, phlebotomy, etc. They can be reduced with cluster care. A parent staying with the child must never sleep in the same bed. Provide another bed or a cot for parent to remain in the same room. Select the appropriate bed for the patient. Some can share a room if they have a like diagnosis, and similar ages can share a room. Protect privacy at all times, regardless of age. If parents need to leave, they must notify nurse so infant can be monitored. Encourage parents to remain at bedside. They fare better and have better outcomes if their parents are present. The family's response to hospitalization. The firstborn, usually parents will be staying, especially if the breastfed infant. Parents feel torn between a hospitalized child and work or other responsibilities. Some families won't visit as often if the child has chronic or more frequent hospitalizations. Working parents may not be able to miss work due to families' limited resources. Some may have extended family stay with child, but not always possible. There are family care volunteers that can come to help with the parents if they need to leave, and there's no replacement. Parents who trust the facility are more likely to leave their child, as opposed to parents who perceive the child will be unsupervised. They will be reluctant to leave. Siblings. They have fear, worry, anxiety, loneliness, angry, act out, jealousy, and resentment. These are both normal reactions. Safety. A wrist or ankle bracelet alarm. If infant or child taken out of range for system, it will set off the alarm. Nurses must respond to alarms ASAP. Follow facilities protocol for abduction. Never let the parents take off the security alarm device. If it needs to be removed for medical procedures, it must be replaced before you leave the infant. Play. Creativity, sensory motor development, intellectual development, socialization and moral development, distraction from stress, anxiety, and self-awareness. Infants, they like solitary play, focuses on sensory motor experiences and pleasure. Toddlers like parallel play, the whole body, multi-sensory experience. Preschoolers, they like associative play, loosely regulated and poorly defined rules can learn social norms, sharing, cooperation. School-age child, cooperative and formal play, contests, competitions, and social groupings. Adolescents, cooperative play, strong interactions, and abstract problem solving. Keep in contact with peers. Provide them with technology if they're able to, so they can communicate with their peers. Educate parents to tell nurses about the alarm instead of silencing the alarm. This goes for like drips, saline drips, IV, that kind of thing. Parents need to know safety, how to lower and raise bed rails, beds, etc. Pumps should be locked so parents or kids can't mess with it. Infants do feel pain. Children can describe pain. Young children can localize their pain. Infants and children do need pain medications. Children who take narcotics appropriately will not be addicted. Use an age-appropriate pain scale to help. Children can lie about pain to avoid medications, and their vitals can also indicate pain. Immediate responses to pain. Decreased O2, increased heart rate, increased blood pressure, heart rate variability, decreased peripheral blood flow, poor wound healing, increased caloric consumption, mistrust in environment, impaired sleep. For prolonged and untreated pain, poor motor performance, poor adaptive behavior, learning disorders, and cognitive defects, temperament changes, psychosocial problems, reduced quality of life. Assessment of pain. Physiological indicators of pain, their vitals change. Behavioral, they withdraw. Physical signs and symptoms of depression. Results of pain tool assessments. You can look at that to assess their pain. Neonatal pain scale. Use the cries scale. Rigid thrashing, general body response. Infants, cries or flack. Local reflex withdrawal, high-pitched loud cry with eyes closed, pushes stimuli away. Toddlers, the cries or the flack. Crying, screaming, inconsolable, uncooperative, verbal expressions with one word, thrashing. Preschoolers, cries, flack, oucha, or faces. Loud crying, screaming can describe pain but not the pain intensity. Pharmacological interventions for pain. You must have an accurate weight as it's given milligrams per kilogram, usually. Always identify and always verify the dose with another nurse. Check respirations. Involve parents in pain evaluation as parents know the child best. Pain is unique. Children don't always behave the same way. Parents can be involved in giving medication if they're educated how to, and the nurse stands there with the parent. This is okay with oral meds. Amla cream can be used proactively to reduce pain associated with common healthcare interventions. Use according to manufacturer's instructions. Assess what parents and child know about procedures before you begin to educate. Give them time. Encourage them to write down questions. Drawing pictures can help. Assent. The child is typically old enough to participate in consenting process by age 7. A child should be with the parent up until the time of sedation for preparing for surgery. They need a quiet and gentle environment. Loose teeth must be removed prior to procedure, as they have deciduous teeth. Document the exact time of last food or drink, bowel movement, urine voided. Consent must be signed, obviously by the parent. I'm not going to have a 7-year-old sign a consent form. Assess for metal or implants. You must have an accurate height and weight for CRNAs. Post-op. Family in room to support child. ABCs, airway, breathing, circulation. Post-op vitals frequently. Assess pain, dressing, IV fluids hanging. Position for comfort. Assess their need for voiding. Recovery. Games can be played for early ambulation, fluid intake, deep breathing devices. Give rewards for dressing changes and challenges completed. They can help remove monitors like pulse ox, that kind of thing. The use of restraints for any situation other than gently holding the child safely and restricting movement during a short procedure requires a physician's order. Always use the least restrictive, assess frequently, a med order required within 1 hour of applying restraint. A mummy hug is a therapeutic hugging. It can be used for IV replacement, a shot, etc. Never do procedures in their safe play area. IVs and central lines. Prevent accidental bolus of fluids or drugs by using only IV pumps with safety devices that clamp tubing when removed from pump. Prevent infiltration into tissues by frequent assessment. Prevent strangulation of tubing around child's neck. Check frequently. Place on monitor. Prevent tissue injury by assessing and report child who cries and is inconsolable or fussy with no reason. May indicate phlebitis or site infection. Don't program more than 2 hours of fluid to be infused. A child may need a central line for some medications that cause inflammation of vein, which are vesicants. Prevention of fluid overload is imperative. Buretrol med IV device is useful for pediatrics. It will not give more fluids than you program it to. Can beep when finished 1 hour or when you program it, but it won't give more than you program. Assess bowel sounds before you give any food. Clear liquids, then progress as tolerated to full liquid, soft, then regular. May have to calculate calories per kilo per day. For a G-tube, this is important. Check the residual, check tube patency before you give meds, or it'll burst on you. Positive fluid balance. Potential for fluid overload. There is more intake than output. Negative fluid balance. Lost more fluids than taken in. Fluid deficit. Most meds can be mixed with syrup if not palatable. Never call the medicine candy. The 10 rights of med administration, you know what those are. Parent can assist with oral meds. IM in vastus lateralis is preferred. You can also use ventrogluteal or deltoid. IV, check patency, check dose with a second nurse, slow push, usually at least 2 minutes. IV pushes you only are in. Otic, which is ear, know how to position ear for the ages. I, get creative with distraction techniques. Topical, kids younger than 6 months, very cautious as it absorbs directly through the skin. Rectal, commonly used if patient is NPO. Specimen collection. Clean catch method. What catch midstream after genitalia is cleaned. Clean catch cotton balls placed in diaper to catch urine. Clean catch U-bag. There's a picture on page 424, figure 23.6. Sterile cath. You know what that is. 24-hour urine collection kept in the specimen fridge where no breast milk is kept. Normally we keep it in the room. Don't want to keep it in the room with kids because they may mess with it. Stool specimen. get it from the diaper. Sputum specimen. Swab nose or throat. If they can't spit, they might be able to spit. Parents administering medications. You can have them watch the nurse, then they can attempt it. Some people are not compliant, so children require longer stays to ensure they get the correct medication. Discharge teaching happens throughout. It can begin on the day of admission. You can give them written documents. The acutely ill child, chapter 24, page 430. You must work quickly and smoothly. As a child goes downhill faster than adults, they may be able to compensate for a while, but then abruptly go into respiratory distress and failure. Usually care is provided by an RN. Safety at bedside. The bed is locked and low side rails up, call light left within reach. Manual recess bag, the ambu bag, and set of masks away from child's reach. Need the correct mask for the child's size. Suction setup. Tube, clean canister, ensure it works effectively. Suction device, at least one present. Tonsil tip, olive tip, bulb syringe, deep sterile suction. Oxygen must be available. Green Christmas tree wall device. Oxygen delivery system such as a nasal cannula. Code blue button. Emergency numbers for rapid response team. An emergency button must be available in the child's bathroom. Codes. Red, fire or smoke. Pink, newborn or child abduction. Blue, CPR needed response team. Yellow, disaster, prepare for incoming patients. Gray, adult missing, doctor strong, security needed ASAP. Rapid response, emergency response team, but not a full code. Use the S-bar communication tool. A high majority of kids going code is due to respiratory problems such as choking, shock, toxic, or anaphylactic. Choking. Airway remains small until 5 years old. Suction mouth is priority if possible. Never do a blind finger sweep. You can further lodge the object in the throat. Watch the video on CPR choking education video. Severe choking is no crying and no sounds. That's important. Shock, hypovolemic, cardiogenic, distributive, obstructive. Restore O2 to brain and tissue. If shock progresses, call rapid response. Protect their vascular access. You may need to use it. There's a graph on page 434 and 435 on pediatric CPR using AEDs calling for help in the wild. Cyanosis. Discoloration related to decrease in oxygen, decreased blood flow. Interventions. Open airway, stimulate child, give 100% O2 via mask suction of obstruction. O2 saturation, cardiac monitor, obtain ABGs, central or peripheral. Those are the different types of cyanosis. TET spells, tetralogy of Fallot, TOF, can cause sudden cyanosis. It can be a congenital heart condition, which is from birth. ALTE, acute life-threatening event, ALTE, sometimes called BRUI, brief, resolved, unexplained event. Acute distress, need rapid response team, could be from difficulty breathing, history of cyanosis, repeat apneic episodes. Respiratory distress, early signs, nasal flare, anxiety, lethargic, retractions, wheezing, stridor, tachypnea. Late signs, poor perfusion, bradycardia, diminished breath sounds, expiratory grunting, and apnea. Epiglottitis is excessive swelling to the epiglottis, causing obstruction to breathing. May need a trach if antibiotics is not fast enough. Child cardiac monitor. White, black, green. Green is placed left. You got white, black, green. Green is left, and then placed below the black, which is also below the nipple. So, white, black, green. There's a picture on page 440. Children with allergies must carry an EpiPen. Charge nurse is typically the one in charge of checking the crash cart, making sure it's ready to use. A lot of equipment is organized by weight range. With Broslow's tape, it's a good indicative tool to use under the age of 12 to gauge weight when it's unknown. Measure them on the supine position, head to heel, red to head, then use the color-coded equipment indicated by Broslow's tape. Families who witness crashing or emergencies have a lesser time of grief if the child dies. The nurse must identify who is the legal decision maker and who is the primary decision maker of the family. It may not be the same person. Emergency response team consists of the pediatric hospitalist or the ER doctor, RN assigned to patient, pediatric advanced life support nurse, critical care nurse, respiratory therapist, pharmacist, central supply with extra supplies, a lab runner, and a nurse to provide support to family. Call rapid response team if airway compromise, grand mal seizures, change in neurostatus, level of consciousness, wound dehiscence, significant fall, unexpected or rapid change in clinical status, head injuries, or hemorrhage. CAB, compressions, airway breathing. You need a resus bag valve mask. One member of the team must be delegated to give report to patient's family, must be given calmly, brief, matter of fact, and with direct eye contact. Chapter 25. Adapting to chronic illness with family support. Page 451. Chronic illness with potential to last throughout the person's life. It lasts for more than 3 months and characterized with quiet and active periods. Cystic fibrosis, asthma, type 1 diabetes, atopic dermatitis, sickle cell disease, neutropenia, and various childhood cancers. The goal is to minimize hospitalizations and have a life as normal as possible. When stressed or anxious, illness is harder to manage, and you need to manage mental health, manage the stress. The mental health concerns are poor sleeping habits, fatigue, poor eating habits, nutritional intake, emotional distress, mood swings, fear, anger, talking about death, not cooperating with treatments. Technology-dependent patient requires medical device to maintain health and wellness. Congenital is from birth. Always respect cultural backgrounds and cultural rituals as long as it doesn't pose an issue to facility, so like no fires in the bedroom. Doctor must give bad news. The nurse will never give it. A child life specialist may be needed. ADLs and quality of life is based off symptom management. We can control nausea, vomiting, diarrhea, discomfort, pain, fatigue, emotional distress, anxiety, sleep disorders, dyspnea, and difficulty breathing. Nausea and vomiting is common in anti-cancer treatment, so around-the-clock antiemetics prescribed, not just PRN. Dyspnea, suction, give O2, reposition, massage, a fan, guided imagery, and relaxation. Secondary problems, prevention is best. It includes weight loss, decubitus ulcers, aspiration pneumonia, UTIs, contractures, and muscle wasting. Teach parents or caregivers how to use and maintain the device, how to safely care for and implement device. Hospitalizations. The parent must always carry info of the child and med list and treatments used and previous hospitalizations wherever they go, because what if they get more sick on holiday? Day respite and long-term care. There are summer camps, pediatric nursing homes, and pediatric hospice care available. The child receives cues based on the environment and what caregivers and friends say. Children are very aware that you see them as different. They have a picture of their previous healthy self and may say, "This is who I really am." It's important for the healthcare team to provide child with the highest potential to develop a strong self-image and positive emotional health. Provide a routine for families. Acknowledge that emotional turmoil is normal. Show understanding of the child's distress. Provide a reward system for complying with treatments, etc. Make sure that all adults in the child's life understand the severity of the illness. The most severe rate of depression for children with chronic illnesses are those with orthopedic disorders and require a device to help assist them. If they are frequently around other children with the same or similar illnesses who die, they will be fearful of their own mortality. Parents have increased stress and worry. The whole family might suffer. There's a high divorce rate. Siblings may be jealous, anxious, or fearful. You can encourage joining support groups. Provide information for respite care. Reiterate that no one knows the child like the parents do, so respite providers need to have access to emergency numbers if needed. Parenting continues and the child still requires discipline, honesty, clear limits and expectations. The biggest issue with adolescence and illnesses is that they are non-compliant with meds or treatment. Younger siblings of chronically ill child may be resentful, angry, wish they were sick also for the attention, or believe that they have caused it with magical thinking. They may require family therapy. Sibling rivalry red flags. Avoiding or ignoring the ill child, acting out physically or emotional abuse during play, demonstrating increased roughness or violence towards ill child or between siblings, seeking attention in high-risk ways, for example, sexual promiscuity. Readmission. Too close admissions may indicate that the child wasn't ready for discharge the first time around. A special needs child with chronic illness who requires daily care, meds, treatment, and procedures, for example, autism, Fragile X syndrome, Down syndrome, that kind of thing. Death. Most children understand the situation, but will deal with it on their own unique way. Hospitals usually provide clergy to help with questions about life and death. Infants have no concept of death. Toddlers have no concept that they will have separation anxiety. A preschooler who has magical thinking may believe it's not permanent and they may act out dying. Young school age understands death is permanent, may try to act adult-like, experience psychosomatic complaints and trouble concentrating. Older school-age children have a strong understanding of the permanence of death. They're interested in the details of death, pain, funerals, and burials, etc. Adolescents may respond with grief, strong emotional reactions, and feel invincible and want to try risky behaviors or attempt suicide. The primary importance after death is family. Chapter 26, The Abused Child. The goal is to identify it and provide safety for the child. Nurses are mandatory reporters. You must report suspected or actual abuse. Mandatory reporters include healthcare providers, nurses of course, commercial film developers, childcare custodians, and law officers. It's not the nurse's responsibility to determine the cause. CPS is responsible. In the case of concern for a child, don't worry about HIPAA. You can document evidence and show CPS. Of course, you have to worry about HIPAA, but you can give the information to CPS and law enforcement. It must be within 24 to 48 hours. If you're concerned of a flight risk of the parents, you can call hospital security for the safety of child. Neglect is most common. It crosses all cultures. It's most prevalent in families with poverty. Previous CPS reports adolescents with children of their own. Acts of commission. This is commission. Acts of commission. The responsible parent or guardian intentionally harms the child via physical, emotional, or sexual abuse. Acts of omission. Omission. Parent or caregiver cannot provide adequate nutrition, shelter, warmth, clothing, or education. On page 468, there is an etiology of abuse table. Physical abuse, showing signs and evidence of repeated harm, injury to skin, nervous system, visceral trauma. Clinical manifestations of symptoms of abuse. Lack of or delayed normal growth, language delay, irritable, resists affection, unresponsive to nurturing, vacant eyes, gaze aversion, expressionless face, infrequent smile, weight is below 5th percentile, failure to thrive, shaken baby syndrome, falls with associated injuries in young children, bruises of various stages of healing, slapping or grab marks, tied up marks, bilateral black eyes with upper eyelids blackened, external head, face, oral injuries, boggy scalp injuries, thermal injuries, forced immersion, traumatic alopecia, unexplained fractures, spiral fractures, sexual abuse, physical neglect, i.e. poor hygiene. Never bathe or shower the patient if suspected sexual abuse. Label and document everything until law enforcement handover. Anyone can be an abuser. Usually male, known to family, usually close to work, chooses to work with children. The victim is usually the eldest daughter, when it's father and daughter or stepfather and stepdaughter. A male is less likely to report when they are the victim. Munchausen syndrome, fictitious syndrome. Symptoms are not present when the parent is absent. Symptoms are not present in front of the healthcare workers. Parent typically viewed as very caring until the pattern of bizarre attention-seeking behavior is identified. Testing history not supportive of claims. Symptoms not witnessed disappear when mother leaves. Specimens don't match the patient. Chemicals are found in child's body secretions. If suspected, healthcare team must be alerted, but not inform parent if they may leave AMA. 1 in 7 children experience abuse. Long-term consequences are obesity, smoking, drug misuse, alcoholism, depression, high-risk sexual behavior, and unplanned pregnancy. It's estimated 41,000 children die each year worldwide as a result of abuse. Prevention before it occurs is the ultimate goal. Affordable parenting counseling classes educate parents to count to 10 before disciplining the child. Match discipline to the child's developmental age. Be reasonable. Let the punishment fit the crime. Good self-care for parents. Manage stress and anger. Short-tempered parents are at risk for abusing their child. Priority. Stabilize child. Protect from further harm. Take good history. Collect specimens. Secure the photographs. Differentiate between child abuse and other medical conditions. Determination of spiral fractures. Rule out congenital brittle bone disease. Distinguish between abuse and cultural care practices. Page 474, a care plan for the victim of abuse. A child who has experienced neglect, emotional abuse, or physical abuse may display fear, irritability, aggression, withdrawal, and apathy. It's expected that 800,000, at least, humans are involved in human trafficking. 25% of these are children. The most at risk for human trafficking are the homeless, runaways, living in poverty, foster care, youths who use illegal drugs or other substances, and LGBT youth.